Good morning, ladies and gentlemen. Um, just to put my paper into context, remember that this is the second of three papers. The first paper presented by Walaiporn provided, you might say, the external challenges to the public hospitals. My presentation will focus on the internal issues for governing public hospital performance. Well, these are the three authors that prepared this presentation. We actually have a fourth author, Stefan Jost, who couldn't attend the meeting. But he's part of the authorship of the paper. This paper is still in progress, and we hope to complete the draft. But we will give you an idea of what we're thinking in terms of the content of our paper. Let me begin by putting into context the thinking around the performance and the governance of public hospitals. And let me put that in the context of the way the health system or the health sector has tried to govern itself over the last 25 to 30 years. And if you have been around long enough in the 1980s, you will remember that there were a lot of health sector reforms launched in the 1980s and the 1990s, looking at how the health system, how the health sector could actually provide better care to the population. And this was the time when the World Bank, for example, went into this area and produced a lot of their studies on health sector and the demographics of the populations that they served. Given that, one of the main trends, if you remember, in the 1990s was in fact the decentralization of the health system. In my country, the Philippines, the decentralization and the devolution actually occurred in 1992. And I was part of the ministry at that time. It was actually a very abrupt change from a central organization to a decentralized organization, almost like night and day. Because when they signed the law, we had to implement. And if you recall, very recently, 8-10 years ago, I don't know the exact date, Indonesia also decentralized its health system. And so within that context, the improvement of governance as well as performance of the health system was actually highlighted in quite a number of WHO reports, World Health Reports as they call them. And for example, you might remember if you were around by this time in the year 2000, there was this report that actually ranked the different countries as to their health systems. And there were three main, you might say, parameters in which they looked at the health system. If I recall correctly, they were looking at public health outcomes, including infant mortality. They looked at the responsiveness of the system, and this had to do with how the system, for example, responded to patient demand, and how the system provided financial protection. So that was a, you might say, a milestone document in the year 2000. But there were others that followed. And during my stint because I worked in Geneva, in 2006, the human resources for health was put in the global agenda, and a World Health Report entitled Working Together for Health was produced. And this was the time when they also launched the Global Health Workforce Alliance to look at issues of the health workforce. In 2008, for example, there was primary healthcare revisited, and 30 years after Alma Ata, WHO again produced another report that actually revisited the issue of primary health care. And here, they actually looked at how the components of the health system needed to be integrated to provide better care. And then finally, in 2010, the World Health Report on universal health coverage. So you can see that this has been the trend worldwide over the past 20 to 25 years. So with that as the context, and given what Walaiporn has presented in terms of all of the demographic and epidemiological trends, we then ask ourselves, how do you then assess public hospital performance and governance? And that is the topic of my chapter. What's performance? I guess it's doing things well, it's doing things better. And as I said, in 2000, they tried to look at certain parameters of health system performance. There was the component of its impact on certain indicators, like mortality and maternal mortality and infant mortality. It also looked at, for example, financial protection as one of the ways that the health system performed. If you think of that, the health system then, what would be the performance of public hospitals, which are part of the health system? And recalling what Walaiporn said, that public hospitals are only part of a bigger system that needs to provide the health care to the population. So this is the challenge that we, authors of this chapter, need to figure out. And how do we actually represent the issues of governance and performance in these 7 countries that have initially provided write-ups in Volume 1. Let me begin by just talking about 2 major things. The first one, in the next 1 or 2 slides, will be looking at the relationship between the macro trend of decentralization and hospital autonomy. And this is a quote from Volume 1 that says that in the context of public hospital governance, the trend over the past several decades has been away from centralization, away from the command and control by central ministry. That has been the trend. Of course, not all countries have followed the trend. Measures that lessen central authority and increase managerial autonomy of individual hospitals, accompanied by marketization forces, have been pronounced trend in hospital governance worldwide. So if you think of decentralization, less centralization as a trend, how does this picture look like now when you think of hospital autonomy, which, as the slides of Walaiporn showed, had certain positive and negative effects on the system? This then is a slide that looks at decentralization and hospital autonomy, because one of the big drivers of hospital performance has been the trend towards decentralization of the health system. And within this context, the increasing autonomy of hospitals. So think of this as centralized health system, decentralized health system, high autonomy, low autonomy. And I have simply classified the 7 countries in this box. It's simplified, but it gives us some idea of what to think about. For example, Thailand still has a centralized system, but quite high autonomy of its hospitals. Vietnam, centralized, high autonomy, or should it be low? Well, I think they gave them, high autonomy, relatively. But Sri Lanka, centralized but low autonomy. What this means is the latitude for the people who run the hospitals to manage their budgets, to use the resources, the revenues that they collect, is much higher. Whereas in low autonomy situations, that latitude does not exist. Conversely, in a decentralized system, you could have high autonomy in the hospitals. And this is an example of the Philippines where the DOH central hospitals give the hospital directors quite high autonomy to use their budget. That wasn't the case before. In the past, all the money that went into the hospital, if they collected anything, went back into the central government's funds. And these other countries, Indonesia and New Zealand, seem to show that high autonomy as well. India, I am cautioned, is debatable. I put India here as high autonomy, but Nima is telling me maybe we should look at that more closely. Look at this interesting situation here, where it's decentralized but low autonomy. And this is Philippines as well. Because in the Philippines, with its devolved system, the provincial and district hospitals are now under the governor. And the governor's office does not provide very high autonomy to its hospital management. So that it's classified in this way. So this tells you how varied the situation is in these 7 countries in thinking about the effects of centralization interacting with hospital autonomy. Don't get too worried. It gets more complicated. Because we're now going to look at some of the determinants of performance and how they influence the internal workings of the hospital. And this next table will show you that. This is a table that tells you these are some of the determinants, some of them external, for performance of a hospital. And we've already discussed autonomy. Walaiporn has discussed accreditation to some extent, internal management, and accountability. All of these factors would determine how well, what quality would be the performance of a hospital. How well are the clinical outcomes of a hospital in terms of mortality and morbidity? How well are person-centered care within the hospital? How well is equity and access to the hospital by the different segments of the population? How well does the hospital perform in terms of using its resources efficiently, inputs and outputs? How well or how available are in fact the services of the hospital? For example, does the hospital have a laboratory? Does the hospital have a blood bank? In many public hospitals, not all these services are available. So if you look at the determinants of hospital performance as measured by these, you could look at these in the context of a decentralized or a centralized system. So for example, you could take the example Thailand and say, as a centralized system with high autonomy, how well do its hospitals perform? This is what we're trying to think about now, and to try to make a categorization or some assessment of the different public hospitals in a country. The challenge that we have, and this is my second message, is that there are not very good measurements or data to measure these different domains of the hospital. Let me try to clarify that by providing you some of the measurements that the US system uses to measure their performance. And the next 2 or 3 slides will give you an idea of those measurements. Those measurements will cover some areas of clinical outcome. The measurements may cover person-centered care. They may cover even services here and efficiency. But you can see for yourself. These are the quality indicators for the US hospitals, which apparently is applied all across the US. In our paper, we will probably use the New Zealand system as a basis of comparison. But for this presentation, we were only able to get these. But in the US system, they have measurements for 1, 2, 3, 4, 5, 6, 7 domains. The domain of mortality, which would be clinical outcomes. The domain of safety. The domain of readmission and patient experience, which might, patient experience, for example, would be classified under person-centeredness, for example. Effectiveness of care, the efficiencies, timeliness, and efficient use. In this case, they even have a measure for imaging. And let me give you examples, one example each of these indicators for these domains. What's an example for mortality? Here. Death rate for heart attack patients. And they measure that across all of the hospitals. For safety of care, catheter-associated urinary tract infections. For readmission, the rate of unplanned readmissions of pneumonia patients. For patient experience, patients who communicated that their nurses communicated well. In fact, they have an indicator for patients who communicated, patients who said that their doctors communicated well. Remember, these are only one out of several examples. For effectiveness of care, patients assessed and given influenza vaccination. Timeliness of care, average number of minutes before outpatients with chest pain or possible heart attack got an ECG. Efficient use of medical imaging, outpatients who got cardiac imaging stress tests before low-risk outpatient surgery. So this gives you an idea that within the US, they have this array of measurements for the performance of their hospitals. What's the situation in our 7 countries? As Volume 1 says, one aspect of performance that has not received as much attention in reforms has been the quality of care. The observation is our countries still are not able to measure many of these internal parameters for performance, which probably is the biggest takeaway message for Volume 1 for focusing on future reform. The only country of the 7 that have specific performance objectives around patient safety and quality of care was New Zealand. But other countries are commencing hospital accreditation requirements. Well, Thailand has been at it for 18 years, I guess. You probably have your quality indicators already. And in the Philippines, for example, because of PhilHealth accreditation, looking at certain indicators are needed. But I think, and my final slide is this, if you think of trying to assess performance, the reforms have to look at the structures, that exist in hospitals. How can you measure, for example, hospital-acquired infections if you don't have a microbiology lab? And the question is, do you need a microbiology lab in all hospitals? Or in resource-poor situations, do you have to network the use of a microbiology lab? And these are some of the questions that are so important to consider, particularly in countries that don't have that much resources. What systems do you need to improve? And certainly, if a country does not have an integrated hospital information system, then it's very hard to be able to monitor these indicators. Do we have the people to do that monitoring of indicators? And finally, the processes for doing them. So thank you very much, and thank you for your attention.